Hi, this is Muhammad Athman in a new video regarding gravity-assisted colonic ESD. So you can see here granular lateral spreading polyp and the descending colon, and you can see how it's in slightly unstable position, but we're using a device over tube, rigidizing over tube for stability. And you can see here with NBI, there's increased vascularization and possible maybe high-grade dysplasia. So I don't do tunneling in most of the cases, and what I would like to show here, the gravity-assisted technique, which is alternative to traction. So if you want to do standard ESD, which is like circumferential incision around the lesion, you will have to do one of two things. Either allow gravity to help you to track the lesion, or use traction device. In this video, I'll highlight how you can use gravity for your favor. You can notice here early on that the liquid is actually in the upper side of the screen. And right now we're doing the circumferential incision around the lesion. And that circumferential incision will allow us to ensure we're getting clean margin all around. You notice here that I'm also using the injection port of the knife to inject while I'm dissecting because in the initial cut, you might go deep a little bit. So if you keep injecting, or at least make sure that you are getting only mucosal cut to the submucosa and not going to the muscle layer. You can see here I'm waiting to inject a little bit and then could perform the incision. And you can see here we're doing full circumferential incision. For people who are doing bucket technique or tunneling, they would not do full circumferential incision. But if you want to use traction and gravity to help you, that would be the option. So right now we can see that the water and everything is going behind us, which tells me that if I just focus a little bit in dissecting the front of the lesion, it will start to retract. So notice here that initially I worked very close to the mucosa, and I have a good margin of normal tissue, which allowed me to dissect first on the mucosal side. And once I dissected, I exposed the submucosa. Now I'm going deeper in the submucosa. So initially it would be superficial in the submucosa, just under the mucosa, to open your flap. And once the flap is open, the gravity is pulling it to the back. And now I'm going in the right to the left side, ensuring that we open it, and I'm dissecting just above the muscle layer because now we are under the lesion. You can notice in granular lesion, they will have a good blood supply. And you notice here, I'm ensuring to dissect the right margin of the lesion. The right margin is in a different plane. So most of the lesion are in one plane, which is at the lower end. However, the right side is going up to the side, which means it's another plane. So you have to gradually dissect it. So we're using gravity here to dissect front to the back and allow the lesion to retract to the back. And now we're using also coagulation grasper to take care of the main feeder, the main blood supply of the lesion. This will allow us to have a cleaner dissection without bleeding after we expose most of the lesion. It's very important when we dissect over a fold like that is to inject. So now we dissected in the front of the fold, going beyond to the back of the fold. And you can see now we reach to the end of the lesion on one side. And this is a good news because the moment you reach to the oral side of the lesion, which is the distal part from you are looking, now you know that you can utilize that back margin that you created at the beginning and go from one side of the lesion to the other. So you can see here, the more we dissect the left side, the more is the lesion retracting to the right side. And I will just continue to dissect. This is an example when bleeding can happen. Sometimes a knife could be enough, but you would notice here, although there is bleeding, I will inject, and this injection will cause tamponade, and dissect further to expose the blood vessel, because if I try to coagulate it and I don't have enough space, you may not be able to coagulate and it may cause problem. So now once I dissected further, we used another 2 taps and then the bleeding stopped. This trick works more in colonic ESD, particularly right side colonic ESD. It may not work in the stomach because the stomach blood vessel is larger, so be careful about that. And now we can retract the lesion all the way from the left side to the right side. This is the final cut, and we can see here we identified the margin which we dissected initially. So in this video I showed that you don't have to do bucket or tunneling. and just by full circumferential and using traction, using gravity as a method of traction, we're able to remove the lesion nicely. We're using over tube for stability, and through the over tube you can get the lesion out. And then in 1 second you'll enter, you see, inspect the lesion, look for any muscle injury. We don't see any muscle injury here, although this lesion in a fold. Close versus no close. You might, since there's no muscle injury, leave this lesion without closure. However, for larger area, I prefer closure for delayed bleeding, particularly if the patient are taking anticoagulation. So I'm using here the TAC system for closure. It's for TACs. And I'm showing here how you place them. So basically, you don't want to be greedy and try to close all the lesions with 4 TACs. It's not going to work. It will form a tent. It's not going to work. So they have to be close to each other, but not so close that they become inefficient. So I usually try to close up to 4 centimeter with these TACs, and they work the best from the distal margin to the oral margin. So you go distal, oral, and you use it in a zigzag pattern, as you can see here, 1, 2, and this is the third TAC on the back side. And then the fourth TAC, I'm going to put it on the other side here. I consider this system as an approximation device and not closure alone. So despite of using it to close both sides like that, I'm going to put clips over it, and these clips will prevent it from opening and will ensure we're having full closure, not only approximation. I hope in this video showed you a closure technique, a new closure technique, and also the gravity assisted technique. And in other videos will show how traction can work when gravity does not work. Thank you.